afternoon, and I'm going to talk about new imaging. Hopefully that'll be interesting to people. And I'm a medical oncologist, and I've spent about a decade doing this, so a lot of time and energy put into it. I have to introduce the technology first, if you don't mind. This is ultra-low frequency transmitted ultrasound. It's not reflection ultrasound. It's not AVIS. It's not breast ultrasound tomography. It's completely different. It's the only isotropic imaging modality ever developed. We were given $20 million by the NIH to develop this to replace MRI. So I want you to enjoy not just the statistics I'm going to tell you, but I want you to see the images here. This is tricky.
You just gonna give that up.
Yeah, that's one. Okay, so basically, make sure I get the pointers here. There's a transmitter here, and it transmits a plane wave. This is not like regular ultrasound, which is a focused beam. It's also very low. It's 0.3 megahertz. You guys are used to, 15, 20 megahertz. It's very low. It has a receiver on the other side, which I'll show you, and then it has three reflection transducers. It is a water bath base at this point in time. So this is the transmitter array here, and it transmits a field of ultrasound across through the breast, which is here, and on the other side you see there's something called scatter. This comes out of oil exploration technology. It does not come out of ultrasound or MRI or image processing in the conventional way. It has 2,048 cameras on this side, or detectors. And each of the breast exams that we do is 40 million voxels. Okay, that's a lot. Each of those 40 million voxels is looked at from 1 billion different vantage points. So we end up with a huge data set. The number of calculations per breast is 38 times 10 to the 15th. Okay, so it's an amazing thing. All that's done in about 4 minutes. It's about 1,000 times more data than you get with MRI. That's why it's 5 to 10 times higher resolution than MRI, depending on what you have. So if you use regular CT or MRI, the field that you're seeing in backplane projection is this thin red line. Okay. It's also what you see with MRI. It's also what you see with breast ultrasound tomography, things like delphinus. But you can see the sound as it goes through the breast here scatters, okay? And that scattering is what we look at. So we look at this entire field here. And you can see the ultrasound energy going through the breast here. So the technology that we use to do the image is called inverse scattering. So we actually look at the scatter. We end up with billions and billions of different data points. And any of you that know what isotropic means, this means it's absolutely perfect. It has zero error, zero artifact, and it's 99.9% accurate for dimensions and volume. Hate to go through this too complicated here, but just show you some images. So this is what happens when you do two-dimensional imaging. Over here on the left, this is what happens when you use isotropic imaging or basically inverse scattering. You can see down to the level of the single cell with this technology. I'll show you some pictures. So this was a breast image, whole breast done here at UCLA. So this is the entire breast image. This is the transmitted ultra-low frequency. You can see all the ducts and all the glands. You can see them separately. So literally down to the level of histology. Each of the tissue types has a unique speed of sound. So those 40 million voxels each has a speed of sound number. And that number tells you whether it's a gland or a duct, or it's a cyst or a solid, and so forth and so on. This is very important. I don't know whether this next thing is going to work, but each of these is a segmentation of different breast tissue, all from the images that we get from the Ductal. So some of you have seen this little thing that I brought over there, and any of you that want a 3D printed copy of the breast duct system of a living woman, just email me or whatever, I'll send you one. But this is the only technology that's ever been able to do this. So there's no glands here, there's no connective tissue here, there's no fat. This is just the breast duct system, and we learned a lot about it, things that we didn't know before. And I'll talk about what Dr. Love has done in terms of advancing this particular situation. So the images themselves looks like an MRI in the sense that you just scroll through it, but we're scrolling through a volume. We're not scrolling through slices, so it's quite different. Very, very accurate. The top three are the transmission images: the coronal, the axial, and the sagittal. And these are the reflection tomograms here that are refraction corrected. So unlike regular ultrasound, which has artifacts, there's no artifacts in this particular set. So again, this shows basically what a cyst looks like, and as you go through here, you'll see the cyst will show up. How do we know it's a cyst? We know it's a cyst because the speed of sound here is the same as the speed of sound of water. We know that that's not a solid lesion. This patient obviously had a normal mammogram here on the left. This is interesting. This is DCIS. People say ultrasound can't see calcium. We can see calcium better than the mammogram. And the interesting thing about DCIS, this technology, is we can quantitate the calcium, give you a calcium score, and show you whether that patient is responding to her treatment, if she's on pharmacological or hormone treatments. So we'll just go right into this. We are FDA cleared for quantifying breast tissue, fibroglandular tissue, or duct tissue, or glandular tissue as neoadjuvant. So we are FDA cleared to do that. This is shows you the difference between the calcium in the QT scan and the calcium in the mammogram. So you see much better calcium detection. And again, this is the patient with DCIS who was on a program of tamoxifen. You can see her calcium score here, 2020 to 77, and it went down to 19. So she actually was responding to her program, and there's really nothing that can do this. Doubling time is very important. I mean, everybody wants to find biomarkers and all this kind of stuff, but I can tell you that if the doubling time is accurate, and ours is very accurate, you can have tremendous clinical guidance here, because doubling time of non-invasive cancers is very long, doubling time of progressive cancers is very short, and with an isotropic imaging modality, you can determine a doubling time in just a few weeks. You don't have to wait 6 months to determine a doubling time. So I won't go through all the situations here. So this just shows the doubling time for cancers is very narrow, and those that have benign conditions or whatever. So I think that the doubling time is something that tremendous value in oncologists is important to me. We have had a whole body of paper accepted at academic radiology. You'll see that coming out soon, but I just want to show you some pictures because people can't believe that if there's anything better than MRI, which is the gold standard. This is a newborn piglet. We are developing the first body imaging modality for infants, and it's going to be fantastic. This is the MRI, the 3 Tesla MRI of the small bowel. You can see here the lumen, the muscle groups here in the small bowel, and it really is a nice technology. This is the kidney. There's no contrast use here at all. You can see the structure in the, in different parts. You can see the actual tubules here in the medulla kidney. So really nice. We can see down to the layer of a single cell. That's shown here. This is what the eyeball looks like, traditional MRI, CT. You can see here. You can see actually all 3 layers of cornea. You can see the retinal space. So very, very nice. And just to show you one final picture here, this area that we're seeing here is a single layer of cells, which is, of course, this membrane from here. I won't go through the orthopedic stuff here because I want to make sure there's plenty of time, but we can see all the things that are image voids in the MRI. Lung is another interesting one. MRI is not very good at lung. Here in this neonatal pig, you can see the bronchi and the parenchyma. You can also see inside the bone. Interesting. Okay, now let's get into what we're doing here. Dr. Love called me a couple of years ago, and she said the head of imaging at the NCI, which had given us all this money to develop this, said you might be able to help me. That I'm interested in looking at the ductal anatomy. So she came up and she visited. She brought some women. We started doing this, and we showed her that we could actually do unique ductal anatomy, which she thought was very important. So we did over 400 scans in almost 50 women using this technology. So I think basically why would we want to do this? I think, again, as you've seen today, delineation of changes as a woman passes through all the changes that we talked about in this conference. For research, it's going to be very important. I can certainly see for people that are doing pharmaceutical trials where they have to have repeated MRI. Usually the FDA doesn't allow you to do an MRI more than every 6 months. You can do this every day, you can do it every week, you can do it as often as you like. There's no radiation. Well, you laugh at this, but if you're a baby in a neonatal intensive period, you might need to have yourself scanned twice a day. So this is something that's going to be really important, I think. Back. Go back one, sorry. The first, next slide. Okay, so I think for clinicians, it's very important to measure effects of hormone treatments or other things, particularly the SERMs. And I think that previous studies like MRI have not been able to separate the glandular and ductal tissue. And one of the questions Dr. Loves had asked me, what happens during the menstrual cycle? Do the glands and the ducts, do they change? Are the ducts affected by hormones in that sense? So that's the purpose of this study. Next slide here. So the rationale was that we could actually differentiate tissue types and be able to show that there was a statistically significant difference in the different tissues within the breast. So we used this over 400 scans on a number of different women, premenopausal and postmenopausal. So these are the data that we gathered, basically glandular tissue variation, ductal tissue variation, and the changes were plotted over time, and we took them through multiple menstrual cycles. And then, of course, we did all the regular statistics that you're going to see in just a second here to determine. Now, each woman has a different size of her breast, a different distribution of her tissue, so we have to normalize her changes for her breast, whether they're large or small. So there's some normalization we had to do. And this just shows you what the segmentation looks like. This is the fibroglandular tissue component, all automated in the transmission image. This shows what happens at the before the menstrual cycles really gets going here, and this is what happens at the end of the cycle. So there are significant improvements in or increases in glandular tissue. This is not correlated one-to-one with the cycles here. It just shows you that as we looked at these women, the ductal and glandular tissue do cycle through their menstrual period. And again, every woman is different, so this just shows that. So some women have more cycling than others, but they all cycle. And this is just the raw data. I don't think it's going to be very helpful for you to see, but we did look at these patients. This is the bottom line here. And I think that Dr. Love was concerned that if the ducts cycle or if the ducts undergo physiological changes with hormones, that could have implications for her research. So basically the bottom line is the ducts do not change during the menstrual cycle, but the glands do change significantly during the menstrual cycle. And postmenopausal women also cycle. Okay, so even though they don't have ovaries, they have other endocrine effects, probably pituitary, and they also cycle, but they cycle less than the premenopausal women. So this is the conclusions, basically, that the variance, the glandular tissue behaves significantly different in the variance of ductal tissue, and these are all statistically significant. And I think that, again, very high variation. This was unexpected because all the MRI studies have shown there's only 5 or 6% variation, but those are all manual studies, and this is automated, so probably the difference. So there were limitations, as there are in any study. Obviously, the numbers are larger than those determined by MRI in terms of the changes in the glandular volume. But the MRI method is manual, so it's based on the radiologist being able to take out the chest wall and all the other components and just to physically draw around this. We don't have hormonal levels to correlate with these cycle changes. It's obviously not demographically diverse, and it's a small population. So I think that that's the last slide. I'd like to just go over it. So this is an interesting technology. We think that could be a useful clinical method for measuring these effects, especially we're talking to a number of pharmaceutical companies that are using MRI on a repeated basis, which is expensive. You can only do it every 6 months. So this is very inexpensive. There's no contrast involved, 100% safe. I might also say we have breakthrough device designation from the FDA to use this in younger women who have genetic markers, who don't qualify for the mammogram. And talking to a number of physicians here today, there's a lot of women that don't want to have repeated MRIs. So this is a great solution for them. And as I said, the FDA is supporting this. So not all women's tissues respond the same way. For instance, there's only about a 40% of women respond to a given estrogen modulator. So if you're in that business of treating women, you need to know whether they're responding or not. You can tell in just a few weeks whether they're responding and change the treatment if you need to. And finally, the methodology may be useful for people interested in ductal anatomy and ductal fluid. Thank you. This was supported by the Love Foundation.
Yes, that was beautiful. It was really, the resolution that you get with it versus MRI is just mind-boggling. It's absolutely gorgeous. So again, it all comes down to cost. And compared to mammography, is this of equal cost, or where does it lie?
Well, I have a DVT machine in my clinic, and this is a lot less expensive than that. So it's less expensive than a mammogram.
Than a mammogram, then do you foresee that it could take over mammogram? So that you don't have to squish the breast, or do you have to?
One of the things that's interesting is that we've done over 15,000 scans so far, and over half of them are women, direct-to-consumer women that are just coming in to want this instead of mammogram. So I think it won't be driven by the industry. We've already been visited by GE, who wants to buy it and kill it. And so that's the problem. It's a political problem. I think if I were a woman, I would certainly want to have this. Certainly
Maybe this is where we have to ask our advocates to start making noise, yeah? Go up on the hill again.
I mean, it has higher sensitivity and specificity than mammography, handheld ultrasound, and MRI. We have done a study that I think Dr. Love is also going to support, where the false negative mammography rate in women with dense breasts is almost 90%.
So, I just wanted to clarify, is this the only one in existence right now?
No. We have 8 installed systems. I have orders for 13 right now. So.
And then just quickly, the breast was submerged, and you also talked about an infant, so if you were going to do this on an infant, would you have to submerge the baby?
No, the infant scanner we're building has a membrane in it, so the membrane comes around a little baby, and then the water's behind the membrane. Also, quite interesting is that you can do real-time procedures with this. So you can actually do surgery or biopsy inside this device, so which you cannot do with MRI or real-time.
Thank you so much. It's incredible to see the data from this study, which has been such a long time coming, and it's really beautiful. For the premenopausal women, were any of them on oral contraceptives? No, everybody was interested. And then a logistic question, you said you have 8 machines and then 13 on order. Where are those 8 machines? Because I would love to plan a trial using this technology.
Well, the machines are, one is at the NIH, the clinical center. Interestingly enough, we did 85 prostate cancer patients versus 7 Tesla MRI. We had a 90% sensitivity, they had a 60% sensitivity. So this is going to be good for other soft tissue. We have systems in Illinois and in Scottsdale and Nevada, California right now. We also have systems in Europe and in Singapore. So. Yes, sir.
Hey, this is fantastic. I think we're seeing the future here. This is going to change everything for us. We're excited. I have a specific question about breast density. So one of the issues that comes up, density is a risk factor for breast cancer, and density can be ductal lobular units, which increase risk, which we like when they get less when women go through menopause. And then it can be stroma. So I'm assuming this could differentiate density in terms of whether it's stromal versus ductal lobular, that you could quantitate it. And I don't know if you've been doing it long enough to see if, like with chemo prevention, with an AI or tamoxifen, if you actually can see reduction in those
Yes, we can. We are FDA cleared to do what's called fibroglandular volume, so we get a quantitative volume in cc's for the total breast and also cc's with the fibroglandular tissue. So we're the only quantitative methodology approved by the FDA.
So is fibroglandular stroma and ductals?
Yeah, well, the prime
separate out the ducts, right?
we can, but there's no need to for purposes of clinical use.
Congrats. Just I'm going to ask a quick question, a specific question. Have you ever used it for a patient suffering with nipple discharge, diagnosed with intractable papilloma?
Yes. So what would you like to know?
Yes. So, for nipple discharge, charging ducts, we couldn't understand if there's a cancer or not. So we are using intraductal OCT to understand whether there's a cancer cell. And we showed that the fluid ductal hypoplasia and DCS in OCT, intraductal OCT. Just I'm asking, without any invasive system, can you show me the specific intraductal papilloma with your intervention?
Yes, one of the interesting things about our technology is we can tell you whether something is in a duct. So I can tell you whether the calcification is in a duct or not in a duct. And I can also tell you whether the papilloma is intraductal or not. From the clinical standpoint, papillomas are very distinct with our technology. They also have a very long doubling time. So there's a number of features that are useful using this.
Hi, this is a really smart man. So I'm very excited about this kind of technology. I'm a triple-negative breast cancer survivor. So as someone who's gone through treatment and all that kind of stuff, for those who have gone through surgery like mastectomy, reconstruction, can this indicate any sort of like healing issues with the implants, deep flap surgeries, like failure, or like being able to stay up on, especially with the implants, as we know with breast implant illness, is it able to detect things like that and the secondary cancers when it can be implants or teeth that are involved?
Well, this is very good technology for implants. As you can see behind the implant, of course. And, we picked up quite a few implant cancers using this technology. And I would tell you that it's, our friends in Scottsdale, I shouldn't probably advertise it. It's your cancer center, but Dr. Shukla there has a long waiting list of people. She does not want to subject her, she's a radiation oncologist, she does not want to subject her women to mammography after there's radiation for breast cancer. So she can follow the radiation effects by doing the fibroglandular volume and the tissue volumes, and she can also look for recurrence. So, I know it's a new technology, and we obviously need more experience, but, it's, I need to look at it.
How are these, first, thank you for the great presentation. How are these images interpreted? Is it by a radiologist, is it AI, a combination?
Well, I think one of the challenges with this is you can see so much more, and I'm old enough to know pre-MRI. I was actually at UCSF, I ran the cancer center there, radiology imaging laboratory. I was there when we built the first clinical MRI. That's how old I am. But I can tell you the first images were lousy. They were just one of the worst things you could possibly imagine. But the physician teaching aspect of it was very significant. So now you can see nerves and blood vessels, you can see ducts, you can see all the Cooper ligaments, you can see calcification. So, but people that interpret breast MRI have no problem with this. So, a regular breast radiologist or general radiologist does take a little time. We have a teaching set of over 1,000 images that we can help people through that process. But it's like everything, you're going to have to learn.
When I'm already well out of business, they can all of the wheels.
We'll never go out of business. I'm not worried about that. But,
I have a question. Can this technology distinguish what varying different cells are in the eye?
yes, I mean, it can distinguish certainly retinal epithelium from corneal epithelium.
And how about those floater things?
I can't comment on floaters.
Comment on floaters,
But we haven't tried it.
Yeah. Okay.
I don't want to take the next person's time.
I just wanted to ask about this clinical application that you said that I was interested in the learning curve for radiologists. Like if I were to go back to my cancer center and say, hey, can you buy one of these, what the cost is and repair and learning curve for the radiologist said it's analogous to.
Well, the machine costs $400,000, but you can rent it and pay us $125 per scan. I will tell you the financial models are very good, which we can provide. The machine will make money the first month, and you can make between $2 and $3 million of the first 4 years in profit from the machine. It's very profitable. The learning curve depends on, we've trained about 60 radiologists so far. What I haven't told you is that we've done about $10 million in randomized, blinded trials against mammography, and we've got a lot of people trained, so it's possible.
Thank you so much, everybody. We're going to go on a 15-minute break. So we'll be back here at 3:15. We do have drinks and snacks at the Nutrition Hub, and we'll start there today. And cookies.